We talk about cost settlements all the time, and usually agreed. That's why she's here. And like many of us also, serving in these positions, as you know, it's state government. She probably took a pretty healthy pay cut to come back here, as did I, as did many of your commissioners that will be coming before you. The reason we do this is just I wanted to give you a little bit of an introduction. And then, as you know, Medicaid is the biggest part of the Cabinet for Health and Family Services, often complex. Somehow we're able to expend billions of dollars and make everybody upset. But that seems to be what we do. So with that, I will turn it over to Commissioner Lee.
Thank you. Thank you, Secretary. I think some of you know that when I first came back to the Department for Medicaid Services, I gave kind of the same little background about myself. And one of the reasons that I came back, the main reason, is that I really believe in this program. I've worked in it over 20 years. I think we do some wonderful stuff in this state for the members that we serve, for our providers. Sometimes I don't think the program gets enough credit for everything we do, because when there is one complaint about the Medicaid program, but it's not going to give you the full picture of the Medicaid program and everything we do. So we'll jump into it. And I thought I'd start a little bit by talking about the evolution of Medicaid so that we could understand how we got to where we are today. Medicaid, of course, was created in 1965 for a very specific set of individuals. Those are individuals who were receiving welfare, basically. Through the years, the program has been tapped to include other populations, including children and pregnant women, low-income individuals, and in 1997, one of the biggest expansions to the Medicaid program was the Children's Health Insurance Program, because there were many millions of children across the nation who did not have access to affordable health care. And then in 2010, again, we expanded to cover individuals 138% of the federal poverty level and below. And again, I just wanted to give this evolution of Medicaid to show that Medicaid, and as you'll see as we go forward with their presentation, that Medicaid is the go-to program to solve health care issues that commercial insurers are unwilling or unable to solve. Number one, affordability. Insurance premiums are out of reach for so many individuals, even individuals who work for state government qualify for Medicaid. Soldiers qualify for Medicaid based on their income. So again, Medicaid is actually the go-to program to solve a lot of these healthcare issues. We also cover 70% of all long-term care. Again, commercial carriers are either unwilling or unable to address that issue. We have personal supports that we cover in our waiver programs that we'll talk about later, and we also have a child-specific benefit. And for those of you who may not be familiar with the EPSDT benefit, that means early periodic screening, diagnosis, and treatment. It actually it was actually created during or previous close to the Vietnam War. Individuals were going up, mainly young males, were going up for exams before they entered the military, and it was noticed that a lot of these individuals were very poor. They were on Medicaid, but they still had issues and health care concerns that they could not enter the military. So the EPSDT benefit was created to say that anything that a child needs that's medically necessary must be covered under the Medicaid program. So that's why we have that very robust, rich program today for our children under the age of 21. So again, Medicaid, just at a glance, today we cover 1.6 million Kentuckians. That's 1 out of every 3 in this state. And we cover over half of Kentucky's children. And one of the reasons that we do cover Kentucky's children, a large percentage, of course, they live in poverty. We always say that the 1.6 million is nothing to boast about, because that means 1.6 million individuals in this state live in poverty, including those children. However, children are covered under the CHFS program up to 200% of the federal poverty level. So we do cover those individuals at a little bit of a higher income. And I'm not going to go over all of these covered populations. We wanted to put a little slide in here just to show you that we have all of these types of assistance for individuals. And I know sometimes you hear maybe some issues or some concerns, complaints about Medicaid eligibility and the length of time it takes to determine eligibility. We just wanted to put these covered populations up here just to show you it's not just the aged, blind, disabled, pregnant women, children, and individuals under 138% of the federal poverty level. Each type of assistance has their own federal poverty level limits and requirements. So you can see on this chart here, these are types of assistance for children. And this just goes on to talk about some of the other programs, the types of assistance that we cover. Would like to note that on the pregnant women, we have the note under there of the description as a 60-day postpartum. As you know, thanks to legislation, that has been extended to 12 months, which is going to be very great for our families. Particularly our women and children who need those services. Pregnant women, after they have their babies, they're still mothers. And so cutting their eligibility for Medicaid off at 60 days did not make sense. So we're very thankful for that year. We also have a spin down criteria. And what a spin down card is we may have some individuals who technically don't require or don't meet eligibility requirements based on their income. However, they may experience some medical emergencies. They may have a large medical debt, and they can use that debt to spin down to qualify for Medicaid for a very time-limited period. Go to the next one. And again, we're not going to go through all of these. Go to the next one, too. That next one. I just wanted to point out and show that there's at least 25 or 26 categories of eligibility in the Medicaid program, which makes it a little bit difficult sometimes when you look at an application. It's not just yes, you meet, no, you don't. There's a lot of other criteria that have to be considered. And we do cover, for example, individuals who are also covered by Medicare. Some of these individuals receive only assistance with paying their premiums and their coinsurance and deductible. They don't receive the full Medicaid benefit package. And recently we have gone through reorganization, and the Senior Deputy Commissioner has been very instrumental in pulling that all together and making it very successful. So I will turn it over to her to talk about the organizational structure.
Thank you. So this presentation is very timely. We just completed a reorganization. This is a very high level of some of the changes that we made. We went from 5 divisions to 7. 2 divisions had no changes, and those are the ones highlighted in gold there. That's program integrity and fiscal management. But where we really did try to reorganize is to think about where does the program need to go. And some of that is informed by what we've heard from the legislature in terms of oversight of our managed care organizations, focusing more on quality services and outcomes. And so that's what we are trying to achieve with our current reorganization. Under Commissioner Lee's leadership, she is very much focused on us becoming more than a payer and instead being a driver of the healthcare quality and outcomes in the state, since we do cover 1.6 million people. Just to highlight a couple of things from this, one is that we took our former program quality and outcomes, which did both oversight of managed care and tried to focus on quality and outcomes. We split that out. And so now we have a division focused solely on quality and population health. And under that, we have branches that will be focused on equity and determinants of health, on population health, on quality, and also a research and analytics branch that will be helping us make data-informed decisions. We do know that we need to be looking at our data. We need to be determining what is the health status of the people that we serve, and we want to change. We want to turn that information into focusing our policies to drive that quality. And that takes not just fee-for-service, but managed care. So it's across the whole population. And also then we could align with efforts that are going on statewide. We are just 1/3 of the population, so we have to see what is the other 2/3, what's going on with that population, and where, as a state, should we be aligning some of our efforts. So we're very excited about that new division. We renamed our policy and operations to healthcare policy. They're going to be focused primarily, again, on just the healthcare services that we cover, and help us identify, working with our other divisions, help us identify what other services should we be covering? What should we expand? We've heard from folks about dental. What should we be doing more in dental? There are other services we could potentially cover. So the whole point of this is to, again, focus a division solely on the services that we cover. Our long-term services and supports is our former community alternatives. This is and has been traditionally the division that's handled the 1915C home and community-based services waivers. We've now moved all of our long-term programs into that division. So what we were looking for there, so all the nursing programs, nursing home programs, nursing facility programs, what we've done there is tried to align people for both community and facility services so that there's a continuum. If they need to move in and out of a long-term care facility or move in and out of a community program, we now have that all aligned. We created the health plan oversight. This, as you can imagine, as it says, is so that we can refocus our efforts on ensuring that the managed care population, which covers over 90% of our population, that the managed care organizations, that we're making sure that they are in compliance with our contracts, that we have full oversight of those. Under that, we also moved our eligibility enrollment to that division so that those folks can understand, regardless of the program that we might be covering, that what are the eligibility enrollment pieces to that, whether it's under fee-for-service or managed care or some other program down the line that we might end up covering. And then lastly, we created an information systems division, and what we did at the end of last year was move over staff in a sister agency over to Medicaid. These are folks who were working on the Medicaid IT systems, and what we needed to do was ensure that we were, the Medicaid priority was first and foremost in the decisions we were making about the investment in our IT systems. So we created a division focused on that. This is just a little deep dive into the two new ones. Like I said, health plan oversight becomes the new managed care oversight. We created an appeals and complaints, so we're focusing on, this is both for providers and for members. Again, our eligibility enrollment was there, and then contract monitoring.
All right, before you go into personnel, since this is a long presentation, we'll go ahead and take questions as we get them, if that's okay.
Sure.
And Senator Rocky Adams has one right now.
Thank you, Mr. Chairman. And just really quickly, this just kind of sparked a question. So we're looking at data, we're looking at how we do things a little bit differently, we're organizing them differently. One of the frustrations I have with managed care is that our population is still not getting healthier. I mean, we're still stuck in this rut, I think. So this is exciting for me, but like, for example, we're looking at equity and outcomes and policies and data. So we know right now, let's just take maternal health, for example. We know right now that we have too many C-sections in this state. Our maternal mortality rates are higher than other states. We have some real problems. Will this kind of quantify that data, and then we say to the MCO, you have to have X number of OBGYNs so that we don't have so many C-sections? Or like, how does, from a practical standpoint, how will this work?
Yes, you're right on. The whole point of this is for us to be able to do that surveillance and then turn that into actionable policies and to hold the managed care organizations accountable to it. So we would look at, and by the way, right now we are doing, Dr. Judy Terrio, our medical director, is doing a deep dive into maternal health. And, you know, one of the things, again, we got to do was extend to 12 months postpartum. We're very happy about that. There are some other things we're looking at around maternal health that we want to do, and she's working with the medical directors of each MCO to do that. They meet monthly, and maternal health was sort of the number one kind of issue they wanted to look at first, but the whole purpose of that is for us to bring them to the table and create that expectation and what are those measures, and then hold them accountable to it.
Okay, perfect. I just want someone to focus on us getting healthier.
Yeah.
I mean,
And just also from the cabinet perspective, another piece of this reorganization, thank you all for passing it, is that we moved our Office of Data Analytics into the Secretary's office.
okay, good.
And when I've been in secretary's offices before, we had like one guy we called Data Dan used to work over here. And so now we have a group that's working on this because we need to change how we use data. Another piece that we're working on is with the university partnerships. That was set up in the previous administration where University of Kentucky, University of Louisville, all of the universities had formerly just been sending what they wanted to study, what their graduate students were working on, and what we, like a month ago, we said, here's what we need to see to the universities. Here's what we're trying to look at. What are impacts of COVID? What have been the impacts on health, emergency room usage? We've learned some things about telehealth. Are we better off or not? What's the population health relative to that? So in combination with Medicaid, because we have to use the Medicaid, I mean, that's our richest data.
Right.
How do we use that and agree to how that gets used in terms of looking at that data? And we'll be able to bring that back to you all. It's still probably going to be a year out, but certainly as we get proposals from the universities, we can share them with you all what we get. I'm more than happy to do that. So you'll see what we're looking at. And I just think it's Senator Meredith, you talk about this all the time. Are we getting the bang for our buck in Medicaid, right? Senator Adams, I could go on and on about, vaccination rates in our MCOs and how we're doing better in fee-for-service, but I won't want to embarrass the MCOs in that way. So we see this, right? And we know we need to focus on this. I'm sorry, Lisa.
All right, Representative Mosier.
Thank you, Mr. Chair, and I just thank you for this presentation. I love working on this stuff, so this is my thing. And to Senator Adams' point, I would just like to say, some of what we've looked at is falling in line with what this plan is, to collect more data, to really look at what works and what doesn't. And I think a good example of that is the community health worker legislation that we passed, in looking at some of those home place studies and understanding the ROI to be something like $11.50 to 1. I mean, that is a very targeted use of our Medicaid dollars, and I think we are stewards of taxpayer dollars, and we need to make sure that we have this safety net in place for those who really need it. And that's a very good way to kind of address that. Now, I mean, how it gets implemented is maybe a different kind of question. It's complex, and the Medicaid for postpartum women too. So I look forward to working on this. This is exciting stuff.
The other thing that I failed to mention is the other piece of the reorganization that from the cabinet level, but you see it reflected in the Medicaid presentation. We don't have folks in our departments. Like, we have somebody who works on HR. We've got somebody who works on budget. We've got folks that work on contracts. We don't necessarily have people in the departments dedicated to data analytics which I know might be boring, but we don't have that. So we're creating a couple of positions, one for data analytics and one for kind of strategic plan or implementation policy around sort of how you have a project manager when you're trying to implement legislation, right? How do we follow that through? So we're going to create within each of the departments in the cabinet that person who's responsible for looking at their data and then coordinating with the Office of Data Analytics in the Secretary's office. So all of this should be working, hopefully, once we get it all set up, should be working together to get us and you all better information.
And I think the only thing that I would like to add is, I keep asking, what's our baseline? I know Senator Rocky Adams, you see, we're not getting healthier. And how are we going to measure that? What's our baseline? What do we want to look at? And once we get a report that says, here is where the Medicaid population is now, this is where we want to go, we not only want to look at our population in aggregate, we want to compare those MCOs against each other, because we don't want one MCO bringing the others up. We want them to have to look at these measures and increase the health status of the individuals that we serve. So again, getting our baseline and developing a report that we can report out on to this committee or whichever committee would like to see that report, but that constant reporting out on a routine basis so that we can measure the impact of anything that we do, and not only measuring the impact of those policies, but actually taking a really good, hard, honest look at something. When we implement a policy, if it's not working, we're going to have to go back and do some quality improvement and find out why it's not working. Because I think, as many of you know, that providers are constantly coming up and asking for reimbursement, increased reimbursement. We definitely want to take care of our providers, but we also want to make sure that they're taking care of our members. And sometimes it's not just the money that's going to increase access to care or improve our outcomes. We actually need to look at the data, and we need to see where we're making those improvements. If we're not making those improvements, we have to go back and reevaluate.
Yeah, and you obviously have hit a place that excites us. Right now, we compare MCOs, and a lot of times we compare plans. It's called HEDIS measures, and they've been around for a while. And I know that MCOs, health plans, they've learned to pass the test, right? And so those measures don't mean as much as they used to. So it's, I think, incumbent upon us to say, what are those things we're trying to improve in Kentucky? Because some of those national measures, I'm not sure if they're meaning any more 20 years later.
Senator Berg.
Thank you, Mr. Chairman. I've been thinking a whole lot on this subject, particularly this last week, because Senator Meredith did make it really clear last week that he expects our MCOs to be able to step up and improve healthcare outcomes in the state. And, that brings up a whole myriad of questions, most important of which for me is, what's your baseline? Where do you start measuring, and how do you measure? And how do you know you're measuring a single variable, which is almost impossible in this situation because of the composite reasons that people fall under the need for Medicaid to begin with. So you're talking about some of the least healthiest of our populations. And then you're talking about, a patient's right to not listen to their doctor. So, when you made the comment about vaccination rates and what can our MCOs do to improve vaccination rates among the people that they are responsible for caring for, you get to a point where that rate limiting factor is no longer your MCO. Mm-hmm. It's no longer your physician. It is your patient population. It becomes a part of public education, public communication, trying to reach out to the people you're serving, and this is outside of the purview of the MCOs. So I guess what my point is, yes, we can expect this. Yes, we can try to measure it. We can't measure it without a baseline, and we do not have such a baseline at this point. But I also think we're sort of pawning off the problem a little bit. And I think we're putting a large percentage of the responsibility of this problem on the backs of our managed care organizations when it actually really belongs more on us. How we educate our population, how we treat our population, what type of baseline housing do they have, what type of baseline income do they have, how capable are they of actually getting to a doctor's appointment, of understanding the doctor's instructions, of filling a prescription and being able to take it on a routine basis. These are things that our managed care organizations are not going to be able to do for us. And I just want to put that out for people because this is such a multifactorial problem that to choose one pillar and say you're responsible, you're not going to get the outcomes you want. It will not happen because it is not the only variable affecting the system. I just want to make sure people understand that. Thank you.
Chairman Meredith.
Thanks, sir. And I know what a big task this is. Data concerns me because it's always subject to interpretation from someone. And I'll share a war story very quickly with you. You know, my hospital, which I was CEO for 30 years, county was 26,000 population, service area about 100,000. People said I couldn't recruit physicians, but I did. One in particular was an ENT from Canada. Great doctor, trained at McGill. And he came from Nova Scotia. Population of Nova Scotia at the time was right at 1 million. So why do you come to the United States for? He was one of 3 for the whole province. And he was just overworked and tired of the bureaucracy of a federal system. So that's why he came to the United States. But at that time, we had 67 ENT in Kentucky. But the majority of them were in the urban areas. He was one of the real extremes that were in the rural area. So a lot of this goes back to distribution of resources, which I don't think we've ever had an equitable means of doing that. So I think we've got to look at this whole thing. So I'm interested in how this whole thing flows into health care policy. What does that really mean? And one of the things that I've really looked at in the last few months is the states are using deprivation index for allocation of resources, which makes sense to me. But there's so many other elements of this. Another thing I'm very curious about is, I bash the MCOs all the time, and I'm sure we get a value, but part of our issue is access to care, which means access to insurance. We've got a third of our population that's under Medicaid now. We're looking at another program. I know you folks are looking at another program to extend coverage to non-Medicaid population, which I think is admirable. But why do we have to recreate that wheel? It's my understanding that of our 6 MCOs, only 2 offer commercial insurance outside of the MCO product. Well, wouldn't it make sense as a condition of participation in the MCO program, which obviously is profitable for them, that they would also have to offer a freestanding commercial insurance program? Because I get concerned that we're so focused on the Medicaid population, which we certainly should, because that's where our biggest payoff is. But from an economic standpoint for our employers throughout the state, we need a healthy state. If you don't have access to insurance, you're not going to be able to accomplish that. So to me, that looks like it'd be a matter of health policy too, that if you're going to participate on our Medicaid managed care program, you also have to offer a commercial insurance program to employers. So again, I know we're going to have a lot of these conversations in the next 4 or 5 months, but it's a Gordian knot that we're trying to take care of, and I'm not sure where we start, but I think there's some opportunities. So that's all I have, Mr. Chair. Thank you.
All right, you all can proceed on into personnel.
Thank you.
Actually, I apologize.
Yeah, no, go ahead.
I have one question now that I think of it. It's actually more of a request than anything. Last meeting, Representative Bentley did a terrific job of giving us a spreadsheet and a layout of the structural organization of the entire cabinet. And I understand that some of that or I believe the data from that was from 2021, and I know there's been a lot of changes in that time period. Could you all give us an updated flow chart of where we stand today with that? Maybe by next week or so, whatever.
Yes, sir. We will.
So this is just a snapshot of the personnel. At the time we took this, state government, we have people come and go, but 146 full-time employees, 71 vacant positions, approximately 15 temporary employees, and then the 94 contractors. The reason really for the contractors is mostly around the IT systems. It's incredibly difficult to recruit and retain qualified staff in the area of IT. And so that expertise is just really best to get through a contractor situation. And I do want to acknowledge our employees appreciated, and I did as well, the raise that we got on July 1st. We heard from employees how much they appreciated that. So I do want to take a moment and say thank you for that. We are also looking at, as part of our reorganizations, ways to recruit and retain employees and to diversify our skill set. So to the point of equity and determinants of health and the role they play in somebody's health, we're with our reorganization, we'll now have the ability to bring on staff that has expertise in that area. So, again, with our reorganization, we are thinking more about the knowledge base and the expertise that we have, and what can we bring on to help us get to where we all want to go.
So we do have a few slides here talking about some of the specific functions of the department.
Sorry to interrupt you, Commissioner. Can you check just make sure your mic is on there?
It was not. I'm very
All
sorry.
right, thank you.
So I will go over all of that again just for you. But basically, our department functions are many. We do also now, with the reorg, we will be administering the State Health Benefit Exchange Connect. We also administer a very complex technology system. As you can imagine, in Medicaid, we have an integrated eligibility and enrollment system. And what that means is we have this really big system that takes applications for Medicaid, SNAP, and other benefits within the cabinet. It is a very complex system that links to other systems within the cabinet so that they can talk to each other, and we can get some of the very important data that we've been talking about. We do coordinate and provide administrative support for our Medicaid Advisory Council. That is a 22-member panel representing various provider groups throughout the state and that are enrolled in Medicaid. And underneath the Medicaid Advisory Council, we have 17 technical advisory committees. Here's a list of all of those committees, and I will let you know that this is the only format in the nation like this. Most Medicaid agencies have just a Medicaid Advisory Council that meets and discusses policies, procedures related to the Medicaid program. However, Kentucky has 17 technical advisory committees that report up to the Medicaid Advisory Council.
There are two things, if you go back 2 slides, there are 2 things I'd like to expand upon just a touch. How we relate to the Center for Medicare and Medicaid Services, CMS. When we put a state plan amendment in, when we ask for a waiver. You all have been following the 1115 on how we're the 1115 waiver, and they're 1915B, C, I, 1115. You know, we could list a whole bunch of alphabet soup for you. But what happens is we put it into the federal government. They're on a clock. They're supposed to answer us in 90 days. They come back with a question, and then we have like 45 days to respond, and then we send it back, and then they get another 90 days, and they get to ask us another question. And so last time I talked a little bit about the 1115 and being able to expand some on some of our substance use services and transition from corrections facilities into community. We've been on the clock there for 2 years.
2 years.
They can run the clock for a while. So I just want to put that out there for you all to know that it is not from a lack of trying often. The second piece was Commissioner Lee talked about the integrated eligibility system, IEES. Ours is big. It's different because Medicaid's in the cabinet. It includes other programs. So when you apply for Medicaid, you know, we can also use some of that data in SNAP. We can also use some of that data in TANF. We can also use some of that data in child care. Or if you apply for child care, we can look and see if there's eligibility for other programs. Some states have it like that, right? But ours is pretty big. And that integrated system means that as you build that gigantic system, a lot of it is funded by Medicaid because that's the lion's share of folks who are getting eligibility through the system. But it actually helps the cabinet function across the entire cabinet for that eligibility piece. So I just wanted to make those two kind of, so you can kind of understand some of that back and forth.
All right, we can pause real quick for some questions. Chairman Meredith.
Thanks, sir. Last meeting, which Senator Adams and Representative Mosier were not here, we had a lot of discussion about the process for capturing federal dollars almost on a cost report basis. It's like a step down allocation. It gets very complicated. And I mentioned that because when I look at slide, I think it's 11, the personnel with your numbers. Does this really reflect the manpower that is within these areas? If you're having this distribution of resources to other areas to capture the federal dollars, really that should flow back to Medicaid. Is that reflected in here, and how's it reflected?
That's an excellent question. So the way the cabinet set up its cost allocation system was based on number of personnel. So DCBS pays a pretty good portion because they have the most people. Now, it pulls against the federal grants, but that's where a lot of the administration comes from, as well as then Medicaid. When we start pulling by program, and the IEES, sorry for the initials, that's one that we pull by program. So depending upon the program, it will either pull 85% for Medicaid or more like 20, 30%. And there are examples of programs where we more pull like 30%, and there are examples of programs where we more pull like 85%. And that really, the main way it happens for cabinet cost allocation for administrative costs really was set to personnel many years ago. And it's an approved way to do it. It's a really good way to distribute costs from the cabinet based on administration. But yeah, I think the number of personnel in Medicaid is awfully small for a program as big as it is.
Well, and that's what confuses me. And I just want to say again what you said the last meeting. I personally, and I don't think Co-Chair Meade does either, has a predetermined agenda and outcome for this task force. A lot of people have spoken about the previous experience of splitting the cabinet. I'm not suggesting that, but in the same token, I'm not saying that I wouldn't want to take a look at that. But in order to make that determination, I think we have to have a better understanding of what these numbers actually look like.
Right.
I'm not sure this really ties back to this in a means that I can understand it and interpret it. Of each of these boxes here, what percentage is reliant upon Medicaid funding to provide those services? So again, it's not meant as a criticism body, but I don't know this has a whole lot of value to me in determining where we need to allocate our resources. So I think we got to look at it differently. Because again, my motivation for this is make sure we're being as efficient and effective and responsive as possible to providers and recipients, but I don't know in their current structure if we're able to do that. And another thing that bothers me since we've had this conversation last meeting, this one, is how much are we allowing federal payment policy to determine the structure? And, this is obviously intimidating, but it certainly looks like federal government too. And I'm just concerned that are we letting Medicaid policy drive the structure of our cabinet? And if we are we really looking at it in the most cost-effective manner possible? Because we've got all these subsections that is there a possibility to bring it inside and consolidate it? So rather, bring the bust the cabinet apart, I'm thinking maybe, consolidating and condensing it more by truly identifying the resources used and needed for each of these functions, and also build accountability in, because I think that's something we all agree in. There's just not enough accountability. We're chasing each other all the time. So again, is there a different way we can look at this?
So I think what I would like to just add is that our partnership with CMS, so CMS funds a large portion of the Medicaid program, as you know, and we have to be accountable to CMS, and we submit routine reports, and every report that we submit to CMS has to be validated, and they have to know that every dollar that we're claiming from CMS to run the Medicaid program is actually going to the Medicaid program and benefiting the Medicaid program going forward. And we do, for example, if when we talk about our IT system, for example, we have to develop a very detailed advanced planning document, an APD, that outlines every bit of the dollars and the services that we're going to be delivering with that information technology system. So in addition to having oversight at the state level, we have a lot of oversight at the federal level with CMS, and they do ask a lot of questions, and they ensure that all of the dollars that they're providing to the Medicaid program are going to the operation of the Medicaid program.
I don't question that. I truly don't. But it's as simple as, is this form following function or function following form? And I suspect it may be
I think
form following function.
Yeah, I think it's always going to be a little bit of both.
I agree there is.
I really do. I think we do try to look to maximize the federal dollar as much as we can. We talked about that last week, and so some of that does influence structure, right? I think that's true. But then I think some is just how you divide programs. I sometimes like to say I think of reorganizations and structures as like where you like the couch in the living room. Everybody's got a different opinion, but there's some of that right in the cabinet where we're organized to maximize the federal dollar. Actually, a counterexample, that whole IT piece that's now in Medicaid, that resided outside of Medicaid, and it really felt like I didn't feel 100% confident. I'm sure it was fine. That I could say everything that was happening in that unit related directly to Medicaid. So we took that unit and put it in Medicaid because we needed to feel confident that when we turned to CMS and said, yeah, everything that's happening here is legitimate Medicaid expense, I felt like we had to do it.
Well, again, I'm not questioning the legitimacy of the expense. I'm questioning the efficiency, the effectiveness of the expense.
Yeah.
And again, without knowing how these dollars are allocated to these respective departments, it's proverbial, you can't serve two masters. You know, if you've got a Medicaid responsibility, but you've got other responsibilities as well, which master are you serving? And if this is a small percentage of my section, then I'm not going to pay the attention to that I am my other functions. So a very basic question is, well, then do we need to move that someplace else?
Right.
But what makes it more complex for me is approximately 94 contractors. Again, sorry, I didn't tell them anything. Is that a good number? Is that a bad number? Maybe we should have 120 contractors and shift those resources from one side to the other. So I think we're just going to have to drill down on this information more than what I have here to understand what we're trying to accomplish and how we get there.
Yes, sir.
But again, I understand how we've gotten here. I'm just not sure this is the destination that all of us intended. So thank you.
I will add that for the contractors, a lot of those are the ones that came over with the IT transition. One thing that we have been doing is looking at each of them to see what they are, what duties and responsibilities they do have, if there's any overlap. So we're, grateful to have the Division of Information Systems now that can focus on those things and make sure that we are getting return on that investment. Certainly, I think what we would prefer is to have, state employees doing this job and having.
What do you say then?
What's that?
That you would force state employees to do these jobs?
For continuity, to have the knowledge in-house. I don't. Again, I think in the area of IT, that's nearly impossible because we just can't compete with outside of the state government. But from what we've tried to do is policy related. When we're making policy decisions, that those should be people that are in-house, that are state government employees.
Well, I think that's a fair statement on your part, but I guess I'd have to ask, what other functions within the cabinet could we do maybe on a contractor basis rather than do it internally? Because we've already acknowledged with the MCOs that supposedly they do it better than we can do it ourselves. So what other functions are out there that somebody else can do better and do it cheaper? And I think that's part of the charge of this task force. Is to look at that as well. Thank you.
Senator Berg.
Thank you again. I'm going back 15 minutes into the conversation where we were talking about eligibility, and I do have a question about this because, first of all, I'm going to explain to you how I see this. You're going to tell me how I'm wrong, and then you're going to answer my question if you can. So my understanding about presumptive eligibility for Medicaid comes from my background as being a hospital-based physician. So we have somebody come in the ER, they're in dire straits, they have no insurance, they acknowledge that they have no employment. We have social workers at the hospital who can help them sign up and become eligible for Medicaid. And that's how we've always done it. And then last session, because of concerns for fraud in this system, we changed the rules a little bit. My understanding of what we did is we kept that in place for the hospitals. Even though originally we were trying to take that away from the hospitals, they so desperately needed that presumptive eligibility that we left it in place for them. But we took it away for post-hospital. Like we basically required patients to apply on their own. They couldn't just get that eligibility that they had received in the hospital and take it with them. Now you're looking perplexed, so I'm hoping, sir, I'm wrong. My question was, what is the additional cost to your all's cabinet based on this? Are you all having to go back and recertify patients' eligibilities? No?
So presumptive eligibility is temporary. We do have, originally we had pregnancy presumptive eligibility that was created in early 2000s that was simply for pregnant women, and the providers that are eligible to grant presumptive eligibility for pregnant women are local health departments, FQHCs, OBGYNs. And then in 2014, we created hospital presumptive eligibility, which is the process that you know. So presumptive eligibility is temporary. It just gets somebody in the front door until we can complete that full application. It allows the provider to get paid, and it allows the member to receive services. So during COVID, at the height of COVID, we were very concerned about individuals not being able to go to a physician to seek treatment for COVID and for other issues. So the cabinet was authorized by CMS to be a presumptive eligible agency to be able to grant presumptive eligibility. So we had a simple form online that individuals could fill out. Our system would look at that form and grant that presumptive eligibility if that individual qualified. But we never stopped the presumptive eligibility for hospitals or the pregnancy PE. So the presumptive eligibility that was during COVID was a simple process that individuals could go online themselves. And now, July 14th, that form has been taken down. The hospital presumptive eligibility and the pregnancy presumptive eligibility is still as it always was.
And I can do just a little more, and we can get you the dollar figures, although I can't quote them to you now, but we'll get them to you. We expanded presumptive eligibility during COVID. We did it. We determined ourselves as the agency, and we covered a lot of people. We also did stop it. We were covering at a run point about 120,000 people, and they were not, because we were doing it under presumptive, they didn't fall under the public health emergency and maintenance of effort. So actually, you can actually look at our eligibility statistics, and you can see where we took them off because you see a drop. But we basically got back to where we were, but not on presumptive eligibility. So presumptive eligibility still exists at the hospitals. They have to complete a process, and that was negotiated through House Bill 7, and thank you for that. And nursing facilities can do some of that too. That was a new presumptive eligibility we did during COVID, but that's one that we're allowing to move forward, where you saw all those categories of eligibility, right? There are a bunch of them, and the one that's most complex is called adult medical, and it's when you're getting eligible for a nursing facility. That can take months. What's the value of your home? Do you have stocks? What's the value of your car? Do you have jewelry? I mean, it gets to the point of like, what are your assets? And that takes a long time to do, and can sometimes delay eligibility for nursing facilities for months. And the nursing facilities were struggling at that point, right? We were trying to make sure in many ways how we can get people in more quickly. We did a $29 add-on. That didn't add up to really much of anything for them because Medicare pays so much better than Medicaid. Just a true statement. So, but that presumptive for nursing facilities, we think helped them some. Again, that might be a little hard for us to quantify. We'll work on it, but that's one, again, through House Bill 7 that we're able to continue some, but they're still responsible for completing the full Medicaid application. And that was part of that House Bill 7 requirements.
I guess the crux of my question is, have we taken a lot of people off the rolls, or do we plan to take people off the rolls? And how much more are we spending trying to get those people that no longer meet eligibility back eligible? I guess that's my question.
So when an individual completes a presumptive eligible application, they have a short-term time-limited eligibility. If they don't complete a full application, they drop off. If they do complete a full application and they are granted Medicaid eligibility, they just go on to the Medicaid eligibility rolls. The individuals who completed presumptive eligibility, a lot of those individuals just needed short-term insurance. Maybe they were laid off. Maybe they didn't have any source of insurance. They needed insurance for a little bit of time, and they did not complete an application, so they just fell off of the rolls of Medicaid. We still receive the federal share from CMS for those individuals. We don't have to take any other action on their part. They are not included in, as the Secretary said, in the maintenance of eligibility that is required under the affordable, under the public emergency. So we still get our 6.2% enhanced MAP, which is our federal share for our Medicaid program through the public health emergency. So I think to answer your question, they came on, those individuals that had temporary eligibility may have received a few services. They are no longer eligible, so our administrative cost related to them has ended.
But there's still two answers to your question, okay? And both are valid. One is the folks who were presumptively eligible through COVID have come off the rolls. The rolls, again, we'll show you the month. About 120,000 people came off the rolls. Was it 100? Was it 80 or 100? How many was it?
I don't remember, but it was
Close to 80.
Yeah, I think by the
78.
time people got application, right, it was around 80,000. I'm close. When the public health emergency ends, because those people who come through and done the full enrollment and are in Medicaid but maybe have a new job, so they're above income guidelines, the public health emergency, where we get the extra 6.2%, they can't come off the rolls until the public health emergency ends. Now, we think there are 170,000 of those folks. We think there's somewhere in that neighborhood of that many people. Now, will 170,000 come off the rolls? Over a period of time, they will either be eligible for Medicaid, and we just don't know, or they will come off the rolls. And so that's when the public health emergency, it's just been extended. So we think it's going to go through December now. We just heard like last week. So we think it's going to go through at least December, we think. So that's big. That's big. It's big on budget. But when that ends, then we have to start the process of taking them off the rolls.
And it'll be over a 12-month period. So it's not all 170,000 would drop off at one time. It'd be over the course of 12 months. And our goal for that is to prevent unnecessary administrative termination. So somebody is eligible and for some reason can't get their paperwork in, or we want to make sure they stay on. And then our other goal is to people who truly should no longer be covered under Medicaid, that they get transitioned to a qualified health plan. Because if their income, has increased, then hopefully they can qualify for that and get access to a qualified health plan. So those are our two primary goals with unwinding of the public health emergency, is to help those folks and make sure that they have access to coverage.
And we'll do it within the provisions of House Bill 7 and within what CMS allows. Those are just true statements, and that's how we'll do it.
Yep.
So probably there'll be more folks coming off in the beginning than probably at the end, but that's just how it's gonna roll out, I believe.
Well, thank you all for that answer, and I think the takeaway from that is to realize that this is not the way presumptive eligibility was always done. There was a vast expansion during COVID, and it was MOE, maintenance of effort, was a game changer, or a on the outlook of this entire Medicaid plan, with this federal administration not allowing the removal of those folks during MOE as it is in effect. So, and it's also important that to take away from this that it is not just the state requiring you to clear those roads, that the federal government will require you to do that as well once MOE is lifted. I will also say that maximizing federal dollars is necessary in many areas, and it's a great thing, can help meet the needs and operate and offer those additional services. But I'll also say that we need to make sure that it's completely necessary, because as a state, we look at federal dollars many times as, for lack of better terms, free money. And we have to also realize that we are responsible for the taxpayers' money, to be good stewards of that taxpayer money. And even though these are federal dollars, the people of Kentucky are still paying some of those federal tax dollars, so that we must make sure that we are utilizing that in the best way possible and not overutilizing it, I guess you would say. But I also have a question for you on slide 11. It says there are approximately 94 contractors. what are those all IT, or what's the reason for those 94 contractors why they're not state employees? That's my first question.
Yeah, they are primarily in our information technology, so they work in our systems. We have a few that are, for instance, we've had difficulty recruiting nurses just because of the salary, and so we have had to contract with for some nurses to help us. But it is the lion's share of that is absolutely IT.
And then it says approximately 15 temporary employees. What is the temporary function of those employees?
So we really do try to use temporary employees temporarily. And so these are folks that come on and help us with, for instance, if we're trying to prepare our records for archiving or, it really, the whole point of that is to bring somebody on. We were having a lot of difficulty filling administrative positions. And so we have had to sometimes utilize temporary employees to come on board and help with some of our administrative functions, for filing and that sort of thing. We do still have a couple of our temporary employees are in our provider contact center, but we have been able to, with our online provider enrollment system and maintenance system, we've been able to reduce the number of temporary employees around there, but we still have a few to help with the workload. And so those are the buckets of temporary employees.
Within the cabinet, mostly temporary employees are those administrative positions. The other place we've started using temporary positions is the hiring process, particularly within DCBS. We're able to get people on board more quickly using the temporary process and then leading them through that process to get permanent. So that not here, not in Medicaid, but in DCBS, we use some of that temporary as that bridge of, yeah, we can offer you a job now, hang with us while we go through the personnel process, and then we convert you to a full-time employee. So those are the main uses of, that's the main use in Medicaid, and it's also the main use in the cabinet.
All right. Well, thank you. I think you can proceed at this point. I'm sorry. Senator Rocky Adams has a quick question.
It's an easy one, but it's kind of along the same lines as Senator Meredith was asking about, maximizing these federal dollars, and is everything where they're supposed to be so that we can maximize those dollars. And then he kind of morphed into a consolidation type of inquiry. And it brought me back to the 1915C task force that we started on. And some of those programs are not housed within Medicaid. They're in, Department for Behavioral Health DID. Is it smart for us to house 1915C in other departments, or should we start to look at, why are you scratching your head?
If I may,
Yeah.
this is, I think, one of those really, really, you said it's an easy question, and it's not. It is such a difficult question because my experience in the cabinet, and I think this will be echoed.
Whoever we are.
Whoever we are. That is always a push and pull. There have been times when all of the waivers and all the waiver personnel has been in Medicaid. There have been times when almost all the waiver personnel have been in behavioral health or aging and independent living. We've got a little bit of a balance now. I will tell you what my philosophy is, okay? And we don't always agree, but this is my philosophy. I believe the programmatic expertise, right? The folks who know ID, developmental and intellectual disability, reside in that department. I believe that the folks who substance use and severe mental illness reside in that department. I believe the real substantive aging experience resides in that department. The challenge is, right, it's Medicaid that ends up with the bill, right? So Medicaid's like, no, we need to control this, right? I think I'm portraying that correctly. And so there's always this tension within the cabinet, always. And since I've been there, I actually wrote going back to like I've been every place. The original waiver for individuals with developmental and intellectual disability was called the AISMR waiver. The R is a word we don't say anymore. That's how old it is, right? So I actually worked and helped write those, the very first ones. We've come a long way since then. But there was always, and I did that out of the Inspector General's office, which I had no experience there. I had no business doing it. But we did the best we could. So there's always been this tension in the cabinet of where is the programmatic expertise and where is the fiscal responsibility, and how do you parse that? And I actually don't think it's an easy answer. And I'm not sure that there's a right or 100% right or 100% wrong answer. It really is that back and forth and that tension, and it is tension. It is tension.
And I think all I would add is going back to the responsibilities of the Medicaid program is Medicaid is the single state agency authorized by CMS to operate the program. So the Department for Medicaid Services has to be responsible and is held responsible by CMS for all of those functions. But I do agree with the Secretary that we have expertise in the Department for Behavioral Health, for example. We also have experts in the Department for Community-Based Services and our Aging and Independent Living, and we do work with those agencies and contract with them. And as long as we have a really good contract outlining the responsibilities of each, I think it's a really good marriage.
Yeah, because when I have a problem, I call you. I mean, you're,
Right.
kind of my first stop. And so that was why it kind of sparked why are we doing it this way? But thank you. I appreciate that answer, or as best you can answer.
Right.
Yeah.
And so continuing on, unless there are any more questions, we'll continue on with the services and the responsibilities of the Medicaid program. Of course, our primary responsibilities are ensuring that we're providing medically necessary individuals to our enrolled members. We do have mandatory services and optional services, and I apologize. I have a note here to refer to the latest LRC report, which was just finished today. That's our Legislative Research Commission report for Medicaid that is submitted to LRC on, I think, a quarterly basis. That outlines every single service that's mandatory. It outlines the optional services. It also has our capitation payments to the managed care organizations, the number of individuals enrolled in the Medicaid program during the reporting period. And for example, some of our mandatory services, of course, are hospital services, physician services, long-term care services. Optional services, surprise, surprise, pharmacy is an optional service, but that is only, in theory. I mean, this cannot be an optional service because without medications, individuals would not be healthy. Dental services and vision services are optional for individuals over 21. So when you look at that LRC report, and we can send you a copy to this committee later this week, once you look at those services, anything that is optional is mandatory for a child under the age of 21, and that goes back to that EPSDT benefit. So no service on that LRC report that says optional is optional for under 21. So some of the services that we provide that are administered by other agencies, for example, is our non-emergency medical transportation. This program actually operates very similar to the MCO in that it is a capitated payment model. The department pays the Office of Transportation Delivery a capitation, a per member per month dollar figure for everyone enrolled in the Medicaid program, with a few exceptions. Then the Office of Transportation Delivery contracts with brokers who then deliver services to our Medicaid population. School-based services are another program that we cover. School-based services, even though they are in the Medicaid program, they are not, the cost of the school-based services do not really impact the Medicaid budget because the Department of Education pays the state share on those programs. So we have two forms of payment for our school-based services. One is administrative claiming. So schools that have individuals, for example, that help children or help their families do outreach, or they complete applications for eligibility for Medicaid, are able to claim a certain percent of those costs as administrative, and we can draw down some federal dollars to give to the Department of Education to disperse throughout the schools that are doing that service. We also pay for direct services such as therapies and some nursing services in our schools. Prior to, I think, 2020, all services that were delivered, the medical services delivered in schools, had to be delivered to a child who had an individualized education plan or an IEP. Beginning in 2020, we expanded that service, so now children in schools can receive any medically necessary service that the school has a qualified health care provider to deliver, and that child does not have to have an IEP. That means that we can now reach out this broader to a broader audience of children in school and make sure that they receive medically necessary services. We still that program is in play. We do have approval for it, but COVID came along and it kind of interrupted some of the planning and the processes and education that we were working with some of our schools. So we hope to take that up again soon and make sure that the schools know exactly what they can bill for under those school-based services. Our Health Access Nurturing and Development Services is our HANDS program. We contract with the Department for Public Health. This is a this is a home visitation program that is for first-time mothers or fathers or at-risk parents, and it's only for children under the age of 3. Very similar to First Steps, which is an early intervention service program for children under the age of 3, and we also administer that through the Department of Public Health. And on both of those programs, both HANDS and First Steps, the Department for Public Health pays the state match, and we draw down those federal dollars for those programs. Go to the next one. And when we get into our funding, of course, we've talked about the federal-state partnership. Approximately 70% of our funds are for our traditional Medicaid population. We get 80% match rate. You'll hear it referred to as FMAP or match rate. For our K-CHIP population, 90% for Medicaid expansion. And our administrative expenses are about 50%. We receive 50%. Currently, 3% of our total budget is on our administrative costs. We also get enhanced funding, for example, for our IT projects. When we are in our planning phase and design and development phase of a IT project and we're developing a system, we get about 90%. That amount of funding eventually is reduced. Once we get in operations and maintenance, it can go to 75%. The budget.
So some of you, this may look familiar, that you've seen it before, but this is just the pie chart of the breakdown of where our dollars go. And as you can see, the majority of that is for managed care. Managed care capitation payments make up 79.21%, but keep in mind that's for over 90% of our population. So we're spending almost 80% for about 91 to 92% of our population. The other bucket there for fee-for-service is our nursing facility and 1915C waiver, so that's the intellectually and developmentally disabled population, is what makes up fee-for-service. And there's about 26 to 27,000 people that are in the waivers. So again, a lot of that is nursing facility, but it's for the smaller part of our population. So a little less than 10% we spend over 20% of our funds for. Yeah, do waivers.
Okay, we'll go on to types of waivers. I think we've talked about waivers a little bit here. Section 1115 waivers are often referred to as demonstration waivers. This allows us to just test out new approaches. I think you know that we have, for example, a pending waiver with CMS and 1115 that is to cover services for individuals who are incarcerated. We want to cover substance use disorder services for those individuals. There are also 1915C waivers, which are home and community-based waivers, which are designed to keep individuals in their home or community rather than a long-term care facility. We also have 1915B waivers, which are called freedom of choice waivers. That just allows us to deliver services via managed care delivery systems. And we can go to the next one. So we have a little evolution of Medicaid waivers in here. I'm not sure we need to go through all of this, but basically, again, this is an example of Medicaid being the go-to program to solve those healthcare issues that private insurers either cannot or will not provide. So, for example, our HCBS waivers came about in the 1980. They provide specific services to help individuals remain in the home and community. For example, case management, homemaker services, home health aid, personal care. Those are all services that commercial carriers, particularly personal care, do not cover for individuals that are very vital to them staying in their community rather than having to stay in a long-term care facility. So we talked a little bit about this just a second ago, but we do have 6 1915C waivers, and our Department of Aging and Independent Living helps us with the administrative functions related to home and community-based waivers, as well as supporting of our PDS, which is referred to as participant-directed services. We'll get into that in just a little bit now later, but for all of our waivers. And our Department for Behavioral Health and Intellectual Disabilities shares operating functions for the SCL Michelle P. waivers. They help us administer those programs. This is just a listing of our 1915C waivers, and it just kind of gives you an overview of those individuals who are in those waivers. The Supports for Community Living waiver is the only waiver that does have a residential component to that waiver. PDS, or Participant Directed Services, which we just touched on a little bit ago, allows individuals who are in those HCBS waiver programs to hire their own providers for their non-medical and non-residential waiver services. It allows them more choice, flexibility, and control over their supports. In order to be eligible for the PDS, the individuals have to be receiving services through the acquired brain injury waivers, the long-term, both the regular ABI and the long-term care ABI, Michelle P., or the SCL Supports for Community Living waiver. And their providers can be family members, neighbors, and that again helps us with expanding that workforce shortage area. Kentucky Transitions used to be called Money Follows the Person. You may have heard that referred to as MFP. That's just a demonstration grant that gives the state money to assist individuals from moving from long-term care communities out into community settings. Again, qualified individuals are elderly, disabled. They have to have a mental illness or an acquired brain injury, and they have to reside in a nursing facility and have been there for at least 60 days. They also have to have the ability to live in the community with supports and services provided through the 1915C waivers, and they have to meet Medicaid eligibility requirements, and they have to be receiving Medicaid services at least one day prior to being referred to the Kentucky Transitions Team, or MFP program. Again, as the senior deputy said, we have almost 27,000 individuals in our 1915C waivers. We do have, for our Michelle P. and our SCL, we do have a waiting list currently. Those are two waivers that deliver services to individuals, and we have, again, a waiting list. We do break out Michelle P. of under 18 and over 18. Those individuals on the waiting list, I think there's almost about 10,000 on that Michelle P. waiting list, and about half of them are children. And in that Michelle P. 18 or above, the majority of those individuals came in under age 18 and are still residing in the program. And again, I just point this out because most of the services that the children receive in these waiver programs are therapy services, physical therapy, occupational therapy, speech therapy, because some of them do have private insurance and their insurance companies have limitations on it. Again, an example of commercial insurers being unable or unwilling to provide the medically necessary services that individuals receive. And again, that's why we believe that the children's piece of the Medicaid program and our K-CHIP, the school-based services, are so vital to making sure that those children in Kentucky who receive our services receive all of the medically necessary services that they require to have their best life possible into adulthood and hopefully become healthier adults as they age. We do have two 1915B waivers. The first one we operate under our managed care organizations. Again, it is a risk-based capitation model. Our non-emergency medical transportation that I spoke about earlier, again, is a risk-based capitation model.
I think I just want to add one thing, because I don't think we've discussed this, and one of the values that managed care brings to the state is that, thank you. So for managed care, one of the values that they bring to the state is the ability to do things that we can't do at the department in fee-for-service. They have value-added programs, so they can provide cribs and car seats. They do a lot of gift cards for incentive, especially to access preventive care. So there's a lot of value-added services that they are able to do that we just can't do. They help cover housing and rent and electricity. Again, things that we can't do as a department. So when you think through what all they do, there is a lot that they can accomplish. They can do pilots that we can't do without having to go through a major request for a waiver. They can pay a provider. They can enter into a contract with a provider to deliver value-based services, value-based payment program. I think one of the reasons they bring the continuity of or predictability of a budget, but they also can do all these other things that we can't do.
So we do have an 1115 waiver. The current 1115 waiver that we have extends coverage. It does several things. It extends coverage to former foster care who were 26 and who were in foster care in another state on the date that they turned 18 and who were enrolled in Medicaid. We also have substance use disorder program under our 1115 waiver for all Medicaid members. And it also waives the non-emergency medical transportation for methadone treatment services. We align our Medicaid member redeterminations with their employer-sponsored insurance during open enrollment. This waiver does expire on September 2023, and we are currently amending it to include that SUD for the incarcerated, SUD treatment for incarcerated individuals. We talked a little bit about our Medicaid funding initiatives, and this just gives you just a little overview of some of our current applications and systems that we currently use. We talked about our integrated eligibility and enrollment system, but we also have a model waiver management application that our providers use. We can put case management notes in there. Lots of information to help deliver the care for individuals once they have a plan of care in their waiver program. We also have a managed care organizational pharmacy benefit manager. That was the result of Senate Bill 50. We do have one single pharmacy benefit and benefit manager for all managed care organizations. But each of these are different IT systems, and as you can see, they all have to talk to each other. And so you can see how complex some of our planning and our operations are when we look at our IT functions. Some of those that you see in purple, for example, where they're in a planning phase. Once we get those operational, they will move to a maintenance and operation phase, and that's when I was talking earlier about our funding from CMS will be reduced a little bit. We have some that are currently in procurement that we can't discuss, and we also have some in those planning phases that we're still kind of talking about and again, just planning. And again, just our IT initiatives catalog, you can see all of these in green are the ones that we have in operations and maintenance. They're currently operating. They have information in them, data that we can look at and that help us operate and run the Medicaid program. And with that, we'd be happy to discuss and enter into additional discussions or answer any questions you may have for us.
Well, I think we have a few. We'll start off with Chairman Meredith.
Thank you, sir. And I'd like to go to slide 15, please. Your first bullet there, I just found this one interesting because we've discussed it at length at our Government Contract Review Committee meeting, is why does this have to be a function of the Office of Transportation?
I'm old. We've been in the cabinet forever. Under Paul Patton, under Governor Patton, there was something called Empower Kentucky. And under that umbrella, there was a lot of program design that was done there. Under that program design, what was determined, and this is absolutely what we were talking about and actually what this community is looking at. It was determined that the people who knew how to do transportation were in transportation. And so it was designed that this non-emergency health transportation would be administered by Department of Transportation because they knew what they were doing. And so since that time, this has been the model that's been used to do the non-emergency health transportation program. And there's always tension there. As in any capitation model, is it enough? Are providers getting paid enough for runs? And you'll hear, I'm sure you all hear from your local non-emergency health transportation providers, it's too much, or somebody else can't get in because it's a capitated model. But it started back under Governor Patton.
Well, if my memory serves me correct, this is about it's done under a MOA, about $500,000 a year.
For administrative
For
costs.
administrative.
Yeah. And what's $500,000 a year?
Well, the Office of Transportation Delivery, they do make sure that all the vehicles meet code. They do the inspections. They make sure that the drivers are all eligible to be drivers. They do background checks. For that administrative cost, they do a lot of tasks that the transportation does routinely. And we definitely think that this model has been working for Kentucky, and it's one of the most popular models across the nation.
Maybe, but I guess it's more basic. Is what do we hope to accomplish through providing non-emergency medical transportation?
It's a required benefit. CMS requires us to provide that service to individuals who do not have a vehicle in the household. So it is a mandatory service that we have to.
Appreciate mandatory service, but why?
So because if an individual can't get to their physician, they can't get to their doctor's appointment, they're not going to get the treatment that they need.
I think.
And what happens when that occurs?
Yeah.
Increases the cost of the
Yes.
Medicaid to the Medicaid program,
And
and so I would question why didn't the function of the MCOs? Why don't they have that responsibility?
That's a good question, and I think it's one that we can ask and look at. What I will say to you is this. Anytime we talk to anybody in rural Kentucky or we talk about services in rural Kentucky, transportation is always the number one barrier. It is always transportation. And so that's why I think it's critical. We've always heard that. I also think that's why it's critical that we move as much as we can, as much as rational, to telehealth. And I know that that's also not available in some of our rural areas, but we've got to keep pushing. So between telehealth and really, I think, providing us as much as we can, as much as rational for getting people to healthcare appointments, I think, we see too often. One of the complaints, I think, I don't remember if it was you and I that talked about it or Senator Alvarado and I. I'm sorry about that. But we talked about telehealth in some ways helped some providers. Their no-show rates went down because they were able to engage in telehealth. Well, non-emergency health transportation, I think, supports people getting there. I would think like no-show rates would be worse. And I think probably some health outcomes would be worse. But as I say, that anytime we ask the question, like on a needs assessment, transportation always comes up number one.
Well, I would agree. It's critical,
Yeah.
even more critical to rural communities, particularly during this period of high gas prices that are just crushing our rural recipients. But let me preface that a little bit. I want to thank you for these mission statements that you provided me. But what's missing for me is, how do you measure success? How do you know you've accomplished your mission? And I'd ask that specifically with this program. It's great that we provided, it's needed, but how do we measure success? Just like telemedicine, we kind of did it by, I think we have to admit, by default because of COVID. it expedited the need for that and the importance of that, so we kind of jumped into it. And we anticipate that it's going to save us money in the future. How much money? Right. How much impact is it going to have on non-emergency medical transportation? And who's going to take ownership for that? And that's where you get real return on investment. And I think if we knew what the measure of success for each of these areas, then it also gives us a better understanding as to how the system works.
Yes, sir. And that's where we started, right? We started with data and health data and university partnerships and why we move technology where we do and some of our reorganization to bring some of that data. Because at this point, can I tell you what our baseline is? No. No. And so we've got a lot of work to do to establish that baseline and a lot of work to do. You know, this goes back a long way. But we have the data. We should be able to mine it in a way that protects privacy as much as possible and yet tells us something that should be actionable. Maybe we need to triple what we're doing in non-emergency health transportation, and that would have a tremendous impact on health. Problem is, I can't tell you that.
Well, I think that was evident in passing Senate Bill 50, and that was under the previous administration. Yeah. When we first started having that discussion to go into single source PBM, is no, it's going to cost our program millions and millions. Well, in fact, it has saved our program millions and millions. And with the savings of those millions and millions, now where have those funds gone to? Right. Who's getting the benefit of those? And that's what's missing from this whole thing is how are we measuring success for each one of these areas? Because you can't have accountability if you've got no measurement of success. And I think this non-emergency transportation is a good example. Yep. Super, great idea. But what impact is telehealth going to have on it? What impact is high gas prices going to have on it? So a lot of moving parts here, but I think that's pivotal to really making sure we're spending our dollars as effectively as we could.
Senator Berg.
If I may follow up, it would be very interesting because something like this, we have statistics on OSHA rates and things like that. Be very interesting to try to do a cost comparison over time. If instead of providing continual non-emergent education, we set up a family with a computer and Zoom links, and they are able to complete those visits by telehealth, what are we saving? How much did we spend to begin with, and what are we saving over the long term? Little pieces like that we can measure, we can validate, and would be, exciting data to know.
Yes.
Thanks.
Senator Adams.
Thank you. I had a quick question on page 23, which is on the Kentucky transitions. How many people do we have participating in Kentucky transitions? And can you give me maybe an example of how we're using that?
We have, as the slide indicates, helped over 750 people thus far, and I'm not sure how many are in that right now.
Can you get that for me?
I can get that for you.
Okay.
It's not a big number. Since 2008, 750 people. And what that does is it somebody who's in a nursing facility who wants to live in community. The challenge is this. Once they've been in a nursing facility for 6 months, isn't it? At least 60 days. Most times they've got rid of their home, right? So how do you transition back out? It's a tough thing to do. And that's why it's a relatively small program. The piece that we're putting in place that I'm excited about, we're 20 years late to the game, seriously, 20 years, is the PACE program, which is an all-inclusive program for the elderly, which is where you try to provide services so that you keep folks from going into a nursing facility, not after they've gone into a nursing facility trying to get them out. That's the much tougher piece. But our first PACE rollout is going to be this year. And I since I was in the Inspector General's office, so 95, we've been talking about PACE since then. We're finally going to be able to implement. And that, like the school-based claiming for services outside the IEP, sorry, I'm using initials again. Yeah. That was actually started in the previous administration. Eric, thank you. And so the PACE program was starting to ramp up in the previous administration, and we just are seeing it to completion.
And I'll tell you what my interest is because we do have a population of kids that are aging out and aging through. And so we are, and I've been working on this for years, but haven't really come up with any sort of solution. And that is, we take these kids that are aging out and they go into crisis because we don't have a place to put them. And this money follows the person is, I think, the right path for them to go through. And so I might be following up with you all on this because I have a real interest in this. Thank you.
Representative Bentley.
Thank you, Mr. Chairman. I have 2 or 3 questions for a start. If we go to slide 4, the definition of low-income children versus K-CHIP, is that only dependent upon education?
Children in Medicaid have to be in school or have to be. I'm trying to look at the writing on there. It's kind of small, but there is an educational requirement for children enrolled in Medicaid. And there is also that federal poverty level limit that designates those individuals. So children in K-CHIP, again, the program is administered through Title 21, has a few different rules, and so an educational component is not one for the K-CHIP program. And of course, that was created after the Medicaid program, and I guess the rules for the Medicaid program have never been aligned with the CHIP program.
Okay, that's one. The other question I have is with the open gate policy we have now with people coming into the country, do you know how many immigrants are on our Medicaid in Kentucky?
You have to, in order to qualify for Medicaid, there is an immigration status. You have to be a legally residing immigrant. Individuals who are in the country that are not here legally cannot qualify for Medicaid.
Okay. I had one more. What is the rebates we got back on SB 50?
We're digging into that right now. We're trying to do a report that shows an analysis of all the different components. That includes a single preferred drug list, which actually probably is the biggest return on investment there, where we've moved from preferred to non-preferred or non-preferred to preferred. But we're doing that analysis right now.
Can you give me an approximation? $1 to $1 million?
Oh no, I would say we are up a minimum of 300 million. Too much?
Yeah.
I think that's about.
that's about
I think we're up about 300 million
Yeah.
in terms of rebates. I think I'm really close on that.
And that first year was 324 we found in the black box, right?
Mm-hmm. So it's actually pretty close to what we were guessing.
Yeah. Thank you very much. Thank you, Mr. Chairman.
I think if I could just follow up on that for just one
Absolutely.
second. The thing to remember, and I think this is the challenge of trying to convey what exactly in our analysis, what are the savings or what is the cost, is that we have to front load into the capitation payments the cost of the higher preferred drug, because in a lot of circumstances it's the brand name drug and it's the more expensive drug, even though on the back end we're getting such an amazing rebate from that. It makes sense for us to do that. So we want to be able to explain to everyone that we might see an increase in cost in the managed care portion of our budget because we have to put that in the cap rate, but on the back end the savings that are coming in far exceed that cost.
Yeah, if I could even go a little more on that. The MCOs will tell you, and they will tell you rightly, their costs for prescription medications have gone up. They have. They're paying for more. They're paying for things that we are maximizing our rebate on. So not only are they paying more, they're not seeing the rebates themselves. So their cost of medication, when they come and tell you their cost for prescriptions have gone up, it's true. It's true. It's that the program overall is saving because we're maximizing the rebates. So you have to balance those two out, which is what is complicated. But that's just the true statement of it.
There's the intrinsic piece there, which is full transparency. What we do know now is everybody can see, what do we pay for a dispense fee? What do we pay for a drug ingredient?
Mm-hmm.
And so there's full transparency which you didn't get, previously.
Right.
Representative Mosier.
Thank you, Mr. Chair. This is a big conversation. I feel like we're all over the place. I mean, there are so many things to talk about. And thanks for your comment about the transparency and the rebates, because I think that's really been lacking. And I would like to somehow highlight that so that folks can really see what the true costs are. And because the whole 340B program who set that up? My gosh, it's like so complicated.
It is very challenging, yes.
And a complete lack of transparency. I mean, it just, so anyway, a different discussion. I have a question on back on slide 15, just the school-based services. I've always had a great interest in this, and I just wonder what the utilization is, if you know, and, obviously all the need for health data and the return on investment and understanding baselines and kind of outcomes is going to help inform us make all of these decisions. But, how robust is this? I know it's relatively new with the state plan amendment.
We don't have that information right now. We'd be more than happy to go back and generate some reports specific to school-based services, and even based on region, schools, number of children, types of services they're receiving. And I think it would be a good idea to look at expansion of the school-based services and post to see what kind of new services are coming up.
Yeah, I would love to. I would love to have that information and just see what we need to think about in that space.
We provided, I believe we provided, I think we provided where we have our different counties and what the services are. So in Medicaid, we break down for each county, like the top 10 services paid for adults and the top 10 services paid for children. It's really an interesting read. And we look at different counties. There are different pieces that are up top. And it kind of some of that depends on what facilities are in the county.
Sure.
It doesn't paint the rosiest picture, right, of what the services are that folks are requesting.
Right.
But it's again,
but it's real. I
Yeah.
mean, it tells us what's going on.
Yes.
And then, if I may, one more quick question. You were talking about the transitions program, and I hadn't really thought about it in terms of foster children and aging out, but that's an interesting kind of, program, I guess, to think about. I don't know that it's traditionally meant for that population, but we do need to think about those kids. And I know that we spent a lot of time talking about a potential bridge program. It kind of morphed into a basic health plan. And I think it's on just kind of standby for right now. And I do think that we need, to really get a handle on the data before we, can move forward on anything like that. But is there anything in place for kids who are aging out? I mean, other than just traditional Medicaid, I guess they continue to qualify for Medicaid.
The two pieces I would say, and you all can tell me if I'm missing something. One is our 1115 that we have in place now allows foster children to receive services through 26 if they opt into the system.
Yeah.
And then a bill that was passed recently in the last session allows those folks to come back in, Senate Bill 8, right? That allows those kids to come back in after a longer period of time than we had formerly. So I'm hoping that the combination of that 1115 and that bill will allow more folks to access services. When I was doing homeless services in Louisville, when I'd see a young person on the street, a youth on the street, they're invariably they came through our foster system, invariably. And that's a hard thing to know.
Okay. Thank you.
Chairman Meredith.
Thanks, sir. Very quickly, page 27. Slide 27. Basic health plan. Where are we with that?
So, can I go again? Okay, thanks. So we were proceeding with a we were proceeding with a basic health plan. We had talked to our MCOs. There was some reluctance on the part of, just like you mentioned, for folks going into the private side. There was some reluctance on the part of the MCOs to proceed. There was we can have a lovely discussion about what was in the budget, what wasn't in the budget, what's allowed, what's not allowed, but it's sort of water under the bridge, I think, at this point. Where we went to was, then we started talking to other providers. If we move forward, will you participate? And the hospitals really weren't. And I'm not trying to say, Nancy Galvani, I'm not saying anything bad about you, but if the hospitals aren't going to participate, then there's kind of no sense moving forward, which is where we ended up. As well as then, it was going to be conflict with you all. So with all those factors, we're on hold. We're still developing the parameters of the program. We're still looking at how we develop the parameters of the program and what that might look like. But best case scenario, we're a year and a half out. So
that's
there'll be plenty of time for
That's
discussion.
the reason for my question is, I thought the legislation we passed said we wouldn't proceed with this until legislation develops the proposal for this plan, but yet it looks like we're proceeding. So how are we going to back up and make sure that it reflects legislative intent?
Right.
We're spinning our wheels right now if we haven't been able to do that, and probably won't do that until the 2023 session.
It's going to take a while to even set up the systems to be able to do it. So I feel like we've had the discussions. We're not rolling out, but we are working on trying to see what the parameters would be and what the IT need would be for us to have it in place.
But the original plan was to roll it out before 2023, wasn't it?
Yes, sir. And we're not.
Well, again, why would we be that aggressive with that if the legislation that we passed specifically said that you'd wait for a proposal from us? Who's pushing this?
Well, I think, again, we can have the discussion. Unfortunately, we don't have to. But the way I look at it, there was funding in the budget, right? And what's the last piece? What's the last expression of legislative will? And at that point, feels like it's the budget. But anyway, I'm sure we would have had a lovely go-round about it. I'm glad we don't have to.
Me as well. Thank you.
Thank you all. One follow-up to that, Secretary, and I don't want to be in conflict with you at all, and you have been very good to give me information with that basic health plan. And as we've had some discussions, I think the Cabinet wants to use the basic health plan as more of a bridge insurance program. However, our thoughts on a bridge insurance program are different than that. Ours are that it would be for someone who hits that cliff after they've advanced themselves through employment. They are already on Medicaid. They're already eligible for Medicaid. They hit that cliff, and then they would transition over into that program, not an expansion of any kind. Also, I know that the governor had mentioned that there was, I believe from the press conference that day when he was asked about the basic health plan, that he mentioned there was $230 million or something like that in the budget for the basic health plan, which we never earmarked anything for that. We've combed back through that budget. We don't see anything that points to that amount of money. Now, we did put a small amount in there for some IT work and things like that to start developing programs, but nothing of that scale, which also brings up some concern that if this cabinet is so big that there can be $230 million that the legislature does not notice hidden in that budget, that brings up some red flags for me. But I will also say that what we passed were 2 bills plus the budget with language in it saying that the basic health plan would not be moved forward, would not be developed without the legislature developing that plan themselves, which is now what the Public Assistance Task Force is starting to look at as well. And so I would just say that from our standpoint as leadership in the House, that the governor's comments are not correct with us, that there are many times we budget for things and then later on down the line we say, okay, now you can spend it. His analysis of that the money is there, so that it was our intent to spend it, is not correct. And we would say that anything that is outside of the parameters of what we have in those law, that what is now law, would be complete contradictory to that law. So that would be my comments on the basic health plan. Are there any further questions or comments? If not, the next meeting is going to be August 17th at 3 p.m. right here in this room. And with that, I will accept a motion to adjourn. And we are adjourned.
Thank you all.